Good afternoon. So I'm substituting for Dr. Carruthers today, and it's my pleasure to introduce a scholar and really one of our finest physicians here, Dr. Venkatesh Murthy, Venk Murthy, and we are really fortunate to have Dr. Murthy on our faculty. And a lot of reasons. I'll just give you a little bit of background, but I don't want to take too much away because I learned so much from his lectures. I'll be a little brief. Trained initially at MIT, studied biology and chemistry. Hopkins, he got both an MD and a PhD degree in biophysics and chemistry. He did a year of radiology at Mallinckrodt. I think that really sort of together helps focus how his career turned. Back again to Hopkins for internal medicine, cardiology at Brigham and Women's. See, really an impeccable career. And also did a 2-year imaging fellowship at the Brigham and Women's. And we were fortunate in 2012 to have recruited him here. He was really the top nuclear cardiology candidate in the country, and we were fortunate he chose to join us, both here in the Department of Internal Medicine and in radiology jointly. And very quickly has risen through the ranks. He's currently an associate professor. He directs cardiac PET research. He's got multiple R01 grants from the NIH, has industry funding. He's won very many awards from the Society of Nuclear Medicine, best clinical papers from some of the journals he's published in. And then the one that I personally favor, our cardiology fellows, who are a quite particular lot, selected him in 2017 as being the best research mentor of the year. And that, to me, is very meaningful because I know how competitive that is. He's published about 100 original papers, probably an equal number of reviews and abstracts, and really has become a thought leader in cardiac imaging. And so without further ado, he's going to teach us a little bit about ischemia and imaging and probably other things as well.
Thank you, Dr. Pinsky, for that altogether too kind introduction. Let me turn on this other mic and see if I can make this work. There you go. Okay, great. So the title of my talk today is What is Ischemia and What Does It Matter? Hopefully these seemingly obvious questions, or maybe not so obvious, will leave you thinking and confused and scratching your head a little more by the end of my lecture. These are my disclosures. Of note, the most important disclosure is that I make my living reading stress tests and other kinds of cardiac imaging, so clearly I come at this with my own bias. So I thought I'd start with the first half of the talk talking about what is ischemia. And I kind of have 3 sub-goals here, and one is to describe and remind you all about coronary autoregulation in normal and diseased vessels, to describe and understand what measures of coronary vascular function are useful in clinical practice, and this whole alphabet soup of acronyms we'll go through in a bit, to understand how we might use cardiac PET to measure some of these indices that are useful in clinical work. So this actually started from a Twitter discussion of all things, that one of my relatively recently found friends asked a question, well, what really is myocardial ischemia? And so, I went and I scratched my head and I opened up Brownwald's textbook and I tried to find a description of it. And, shockingly, it wasn't there. And so I went one line and I looked up the earliest version of Stedman's that I could find. And it gave this description of local anemia due to mechanical obstruction, mainly arterial contraction of the blood supply. So that kind of sort of fits about how we think about coronary or myocardial ischemia, except I don't usually think about the word anemia. So I think maybe more a practical definition of ischemia that might be useful today would be insufficient perfusion to a tissue to supply nutrients and remove waste. And we think about this as a cascade in cardiology, starting with a perfusion defect and abnormal blood supply to a coronary vascular distribution. This in turn induces metabolic changes, shifts generally towards glycolysis. The first functional changes we find in animal experiments are abnormalities of relaxation, followed by systolic dysfunction, EKG changes. Somewhere along the line, symptoms start happening, although often relatively late in the process. And eventually, with persistent ischemia, there can be myocardial infarction. So what should we measure clinically, if any of these things? Well, we can measure perfusion, so we can quantify the rate of delivery of blood to a tissue. But each person might require a different rate of blood delivery depending on what they're doing at the time and what their cardiac function is, their blood pressure, their heart rate, their metabolic milieu. We can ask a question about, is the nutrient supply to the myocardium sufficient or not? And fluorodeoxyglucose is a PET tracer. People have used this in research studies to identify shifts of myocardial metabolism towards glycolysis, but this is very hard to do. It depends on the diet. It depends on whether the patient is insulin resistant. It depends on many, many factors like that. There's some emerging data using oxygen level dependent imaging with MRI to actually quantify tissue oxygenation, but this is really primarily a research tool at present, at least for the heart. We can also ask questions about the sufficiency of waste removal. So there are MR methods and PET methods to interrogate things like tissue lactate. Invasively, you can look at adenosine and pH as well. When should we make these measurements? As I kind of alluded to, you can measure during resting conditions. You can try to induce the maximal possible perfusion or metabolism and ask what is happening under those conditions. You can ask what the maximum achievable condition by the patient is, so with some sort of exertion or emotional stress. We can measure reserves, so ratios or differences between a maximum achievable state or a maximum possible state and a resting state. And increasingly in the stress testing world, people think a lot about submaximal indices. What happens when you get to a certain percentage of someone's predicted heart rate or a certain percentage of a person's maximum achievable metabolic rate? So what are the methods that we can use clinically and practically? Invasively, there are a lot of techniques that are useful. People can measure pressures and velocities in coronary arteries using specialized wires. You can do thermodilution just as you measure cardiac output with thermodilution. One can measure intracoronary thermodilution and measure the blood flow in the myocardium in a given coronary artery. You can do lots of calculations based on these and calculate the resistance in the microcirculature as well as in the overall vasculature. But non-invasively, really the only test that's really ready for prime time and widely used clinically is positron emission tomography. There are emerging methods to quantify myocardial blood flow using Doppler echo, contrast echo, CT-FFR, which we'll touch on. And of course, there are research methods about doing quantitative blood flow perfusion using CT, MR, and also with single photon emission computed tomography. So I thought I'd start with this really old image 55 years ago describing coronary perfusion and the regulation of it. You probably saw a version of this in medical school. And this line on the leftmost with the triangles sort of represents what the relationship between flow and pressure in a simple tube would be, a simple garden hose. So if you apply greater pressure, the flow increases. If you have less pressure, the flow decreases. This isn't really all that ideal, though, for a biological system, and it turns out our coronary arteries are exquisitely regulated in order to maintain a relatively constant blood flow across a wide range of pressures. And this plateau is regulated to be appropriate for the level of cardiac effort. So if you take a person or an animal and you decrease their heart rate or their blood pressure so they have to do less cardiac work, the plateau is lower. This ensures that the myocardium gets an appropriate but not excess amount of blood to handle the work that's asked of it. But how does that work? How do you get to that point? Well, here's a little cartoon diagram of a coronary artery with a stenosis, and you can think of this again as your garden hose. So you have a certain velocity of blood flowing proximal to a stenosis. We now pinch that garden hose down, and what ends up happening is the velocity in that area increases. Immediately after the pinch, you get turbulent flow and slower velocities, but after some distance, you get recovery of pressure phenomenon, and the velocities increase again after this loss of velocity in the turbulent region. Importantly, after the epicardial stenosis, there always is outflow into the microcirculation, and the net pressure drop across the coronary artery is something close to the systemic pressure, let's just say 120 for now, and the distal pressure will be something close to the right atrial pressure, say 5. So most of the pressure drop actually happens in the microcirculation, and we'll talk a little bit more about that. Just a little tiny bit of math to take you back. We took you back to medical school. I'm going to go even a little further back to high school physics. Ohm's law. So voltage equals current times resistance. If we translate this for fluid dynamics, the change in pressure equals the flow in a vessel times the resistance. So this is important. This is the one equation that I'm going to focus on. If we rearrange this, the flow, which is what's important for the myocardium to be sure that it gets enough blood to supply oxygen and remove the byproducts of metabolism, is dependent on the change in pressure divided by the resistance, right? So if the pressure falls, in order to maintain flow, the resistance in the circuit also has to fall, right? Otherwise, the flow goes down. So where's the resistance? So this is a cartoon diagram of coronary circulation, and you have larger vessels that are at the epicardial surface and starting to dive into the myocardium. You get medium-sized arterioles, and then finally you get small arterioles that are about the size of a erythrocyte or two. And the regulation at each of these levels is different. The large vessels are primarily regulated, their pressure, their vasomotor state is regulated by shear stress on the endothelium via the nitric oxide pathway. At the small vessel level, the regulation is predominantly via the small molecules such as adenosine and other metabolic byproducts. And in between, the regulation predominantly is based on pressure. But overall, the majority of the resistance in the coronary circuit under normal conditions comes from the microvasculature. We've all seen this diagram, and I promise I won't go into detail, but the point is that the regulation of coronary vascular function is complicated and has been the subject of several Nobel Prizes. The important feature, though, is that the microvasculature is regulated by things like adenosine or its analogs, dipyridamole and regadenoson in the stress lab and in the cath lab. So I said microvascular resistance is the regulator of coronary flow. So we talked about how coronary flow, that velocity is relatively constant across a range of pressures. In this case, we flipped the x-axis, and instead of saying pressures, we're saying diameter stenosis. As you have a greater diameter stenosis, the pressure available in the coronary, you've got a drop in the pressure, and the remaining pressure after that stenosis is lower. Whereas with the 0% stenosis, the gradient is basically the difference between the systemic pressure and the right atrial pressure. Yet you have essentially constant flow across this range. And the reason that is the case is this microvascular resistance, as the stenosis increases, drops off. And that that compensates for this increasing pressure gradient that we see with greater percentage stenosis. But if we take that same patient and we now give them a vasodilator, we give them adenosine, or we give them dipyridamole like you might do in the stress lab, you end up maximally vasodilating the microcirculation, because we said adenosine is the principal regulator of that microcirculatory resistance. And under those circumstances, with increasing pressure gradients because of increasing percentage stenosis, the coronary flow starts dropping consistently across the entire range of percentage stenosis, but particularly dramatically after about a 50% stenosis. So how do you get microvascular resistance to change so much? This is a seminal study done by Jonathan Lindner and colleagues about 20 years ago, and here using ultrasound with bubbles, they were able to demonstrate that the amount of blood volume in the microvasculature increases dramatically with the arteriolar vasodilation. So if you give adenosine or an analog, the amount of blood that's in the microcirculation increases dramatically. And as a consequence, the resistance drops. Going back again to high school physics, you have multiple parallel circuits, the resistance goes down. So how do we use these in practice? So this is a diagram showing the relationship of the velocity in a coronary artery with the pressure gradient in that coronary artery. This is a single coronary artery, so if we increase the flow rate, the pressure gradient increases. You're just driving more blood through a constant size tube. So what ends up happening is under resting conditions, you have a given relationship between flow and pressure gradient. And if we vasodilate, the flow increases, but also the pressure gradient across that vessel increases as well. And when we take those numbers, we can take and look at the change in the x-axis, the change in flow, and we can take that and take a ratio, and we call that the coronary flow reserve. We can make a similar measurement non-invasively with PET, and we call it myocardial flow reserve. It's just a matter of semantics. It's essentially the same metric. In the cath lab, people seem to favor this metric called the fractional flow reserve, or the FFR, which kind of, instead of looking at the delta X on this graph, is the delta Y on the graph. So looking at the change in pressure from hyperemic conditions compared to under resting conditions. So why bother switching from CFR to FFR? We care about what the flow to the myocardium is, because that's what's delivering nutrients. That's what's taking away the byproducts of metabolism. Well, it turns out, as a matter of practice, measuring flow in the coronary artery is difficult. And I don't want to get into the details excessively, but it's more prone to errors and takes more time. And cardiologists, being an impatient lot, have largely switched to invasively measuring the ratios of pressures, or the fractional flow reserve. And it turns out that this measurement is easier and perhaps a little more robust. Going a little bit further, so fractional flow reserve has taken on a major role in cardiology and a major mind share. This is the earliest validation of it, and this group that developed this metric shows that the fractional flow reserve is very closely related to the myocardial flow reserve measured by PET. And the correlation coefficient is pretty good, and they have a pretty good Bland-Altman relationship as well. More importantly, the group has done a number of randomized trials which have shown several important features about how you might manage a patient. So first, they took patients who had an FFR greater than 0.75. So these are people whose pressure gradient across their coronary arteries was not too great, even with vasodilation. And they said, okay, let's randomize these patients to immediately perform revascularization in red, or to defer that and see what happens, and only revascularize down the road if they needed to. And it turned out there was no difference in outcomes, and in fact a trend towards better outcomes by waiting. They went a step further and looked at the opposite end of the spectrum. So if you take those people who have a low FFR, whose stenosis has a significant pressure drop across it, and you randomize them to have PCI guided by that FFR number, or to just angiographically, based on what the interventional cardiologist perceived was the percent stenosis, to revascularized. What they showed was in the FAME trial that outcomes were generally better by using FFR-guided PCI. And in fact, most of this difference, though, was driven by early myocardial infarction, likely peri-procedural, by avoiding doing unnecessary PCIs in those lesions that did not have a significant pressure drop. So this sounds great. FFR should be the future, right? Well, there's a little bit of a challenge. So I showed you this graph earlier. So FFR is the ratio of the distal pressure over the aortic pressure. And that should be this delta Y on this graph, and that should give you very close approximation, should be very closely related to the CFR. However, there is a problem. So, like I said, the CFR was the change in blood flow, which was the physiologic parameter that embodies the delivery of blood to the myocardium under stress conditions. Well, when we take a little step further and we look at a variety of different stenoses, this relationship between the pressure and flow phenomenon is different by vessel and by stenosis characteristics. So the point is that the change in the x-axis does not necessarily predict the change in the y-axis, except for that one given vessel. So by knowing the pressure gradient, we know the pressure gradient, but we don't necessarily know what the impact would be on flow. It gets a little bit worse. So we talked about, we're focusing on the epicardial stenosis, but as I showed you earlier, every epicardial stenosis has downstream of it the microcirculation. And the microcirculation, as I mentioned, is the primary regulator of resistance in the coronary arteries. Well, if we take, say, this particular pressure-flow relationship, and we now say, okay, this was hyperemic conditions with a healthy microvasculature. If we now ask what happens to this patient now that they develop microvascular disease, because they have long-standing diabetes, hypertension, aging, any number of other things, it turns out that when you have microvascular dysfunction, you can't have as much flow through your microvasculature. So your X, you move towards the origin on X. And that drops the pressure gradient. But wait a second. As we bring these two pressures closer together, that actually causes the FFR to be falsely elevated. So you get a more normal fractional flow reserve despite having a lower carrying capacity of your coronary circulation. Conversely, if you do something to make the microcirculation healthier, so this patient then goes out and exercises, recruits capillaries that were not working before, and now they have better flow at stress, so the change in x-axis from rest to maximal hyperemic stress is greater, it turns out now that their FFR is worse, that the drop in pressure apparently is larger. So we've now made a healthier patient but made their FFR look worse. We can go a little bit further. So we talked about all of the relationship between microvascular and epicardial disease. I don't want you to focus on the equations here, but we can separate these using catheterization lab measurements. So we can take the total resistance in the coronary arteries and separate out the epicardial component and the microvascular component. And when we do that, we can ask what's the resistance that's specific to the epicardial stenosis. And if you do that, so this is really great work from Europe, and they take in each of these colors is a different degree of epicardial stenosis. So based on the resistance that stenosis is causing. And let's just for a moment focus on the yellow stenoses. So these are all different coronary arteries, but the amount of resistance that the epicardial stenosis is causing is about the same in all of them. But what you see is that each of these has a different microvascular milieu that it lives in, right? And that's what's on the x-axis. And given a different microvascular resistance, a very similar epicardial resistance gives a totally different fractional flow reserve. It's interesting. FFR also has another interesting property. So we talked about the microcirculation is dependent on how many parallel pathways. Jonathan Lindner told us that, right? Well, how many parallel pathways are in the myocardium depends on how much myocardium there is, as well as the health of that myocardium. So if we have a lot of mass, coronary mass, subtended by a given stenosis, there are a lot of parallel pathways. So this was a really beautiful study done using modeling to estimate what FFR would be using fluid dynamics. And this is something that's been really hot in the literature, CT-FFR. And you can't see the curve, but one of the curves in here is CT-FFR. It turns out they did something even much simpler, though. They asked, what is the cross-sectional area of the epicardial coronary artery? And let's divide that by how much mass is downstream, so some measure of the microvasculature. So a measure of the epicardial circulation divided by a measure of the microcirculation. Turns out that outperformed all the complex fluid dynamics. And why is that? Well, FFR is related to epicardial stenosis. So this is great data coming from Korea, where they showed in about 300 patients that there's a reasonably good relationship between FFR and the percent diameter stenosis in the epicardial coronary artery. But what they also showed with very careful catheterization lab measurements was that the epicardial stenosis has essentially no relationship with what's going on in the microvasculature. But what the third panel that they didn't show is that the spread, a large part of the spread in this relationship is explained by the microvasculature. So let's take another step further. So this is a study of 157 patients from Europe where they asked, in this group, can we post hoc divide up the patients based on FFR and measure the epicardial stenosis and coronary flow reserve, the net flow to the myocardium that integrates both the microvascular and epicardial stenosis. And they asked, what is the rate of major adverse cardiac outcomes in this group? And the group that was the least healthy was actually the group that had preserved fractional flow reserve. So their epicardial stenosis, by what many argue for a gold standard, is not significant, but yet their overall flow to their myocardium is impaired. So they had an extremely high rate of major adverse cardiac events. Conversely, if you take the group that had relatively preserved overall myocardial blood flow, their coronary flow reserve was greater than 2, and you look at the difference between whether their FFR was reduced or not, there really was relatively modest difference overall between those two groups. Still a small study. Another study from Korea, about 300 patients this time, and here they've stratified the group based on epicardial stenosis as measured by FFR and microvascular resistance, and what you can see is the group, again, that's worst is the group that has bad microcirculation. Okay, let's bring this back to the non-invasive realm a bit. So this is, again, work from Europe where they looked at SPECT myocardial perfusion imaging. And what they did, again, here was they divided the group into patients who had epicardial stenoses with an FFR greater than 0.75, meaning non-obstructive by traditional FFR criteria, or FFR less than 0.75, meaning obstructive by traditional FFR criteria. And then each of these colors is a different degree of microcirculatory resistance. So in peach, this is a low microcirculatory resistance, so a healthy microvasculature. And in this kind of cyan color is a high microcirculatory resistance, so diseased microvasculature. And what you can see is that in these vessels that have little epicardial stenosis, even though there are very big differences in microvascular health, SPECT can't tell the difference between those. Conversely, in these vessels where there is epicardial stenosis, SPECT is only really able to identify abnormalities in those cases where there is also concomitant microvascular disease. And the reason for that is that if you have healthy microcirculation, a lot of epicardial stenosis can be compensated for. Let me say that again. If you have healthy microcirculation, a lot of epicardial stenosis can be compensated for. Right? So this also points out a very important limitation of SPECT, that it assumes that the best perfused segment is normal, and consequently, diffuse processes like microvascular dysfunction don't show up as different. These are great data from Cedars-Sinai looking at about 100 patients with left main or equivalent disease. And when you look at these patients, all of them are abnormal on SPECT, but only about a little over half have greater than 10% ischemia on a SPECT scan. So these are patients who have moderate to severe perfusion defects, but the other 45% of them have mild perfusion defects, despite having left main or equivalent disease. And that's because the best perfused segment is presumed to be normal with SPECT. When we add in things like an abnormal ejection fraction, TID, wall motion abnormalities, we get a little bit better, but we're still missing somewhere around 1 in 6 because of our fundamental assumption with SPECT imaging. So the ratio of perfusion between stress over rest in SPECT is an approximation of CFR or MFR, but it's assuming that the region that the best perfused region is normal. Consequently, there's always a chance that we miss something called balanced ischemia. It's discussed way more than it actually occurs. But more importantly, we may miss decreased vasodilator function, diffuse vasomotor dysfunction, microvascular dysfunction in the absence of localizing stenosis. Quantification allows us to get past some of these limitations. So we can assess myocardial blood flow at rest, we can measure it again at stress, and we can take that ratio and call it the coronary flow reserve or the myocardial flow reserve. And as I mentioned, this is really a complete measurement of the effect of the entire coronary vascular tree, including the microcirculation, because we're getting the net blood flow. And if we do this, so this is data on about 2,800 patients with making these measurements with PET, and on this axis, they've divided out the percent abnormality in the way you might with SPECT, just saying how much of the myocardium visually appears abnormal, with normal scans on the right and greater than 10% perfusion defects on the left. And then from front to back, dividing based on the myocardial flow reserve, so the quantitative measures of myocardial perfusion. And what you can see is that the annualized cardiac mortality varies dramatically by both categories, and importantly, that even in those people with normal perfusion visually, having an abnormal vasodilator capacity is associated with almost a 4% rate of cardiac mortality per year. This survives pretty extensive adjustment, and ultimately being in the worst tertile of coronary flow reserve is associated with a nearly 6-fold increased rate of cardiac mortality. If you apply this clinically in stress testing populations and you take those patients that turn out to be intermediate risk, you would predict that them to be between 1 and 3% per year rate of cardiac mortality based on their clinical characteristics and their imaging characteristics, their ejection fraction, their perfusion defects, their blood pressure and heart rate. What you end up finding is that the addition of these quantitative parameters ends up reclassifying approximately a third of these patients downwards to low risk because they have well-preserved vasomotor capacity, and approximately 17% of them upwards to a high-risk group, and they actually have event rates correspondingly. This sort of work has been reproduced now in 5 or 6 other cohorts as well, again showing that the quantitative measurements of myocardial blood flow with PET improve risk stratification. Here's an example. So this is a patient who has a nearly normal perfusion scan. There's a very small lateral defect here that you can see on the stress images. The rest images is the second and fourth row where you see that that defect fills in. The coronary flow reserve, however, in this patient is 1.63, which is moderate to severely reduced. And it turns out that on angiography, this patient has a very ugly left main lesion. So, should we take all of the patients who have a low flow reserve to angiography? Well, I mentioned that this is a complete interrogation of the entire vascular tree, not just the epicardial coronary circulation, but also the microvasculature. So these are data from the Ottawa Heart Institute, where they took patients and based on their overall perfusion reserve, or their coronary flow reserve is another term. Unfortunately, our literature has changed terms multiple times. And on the y-axis, we have the probability of 3-vessel or left main disease. And what you can see is even with a flow reserve of 1.5, meaning your stress blood flow is only 50% greater than your resting blood flow, you only have about a 25% chance of having left main or 3-vessel disease. And in those patients with a flow reserve of 1.0, meaning that they were not able to increase their blood flow at all, with vasodilator medications, they're still only at about a 50% chance of having left main or 3-vessel disease. So why do the others have impaired vasomotor capacity, and why are they having events? It all comes down to diffuse disease and microvascular dysfunction. And this is an illustration of that. This is a young man who was being evaluated prior to renal transplant, had all of the risk factors despite the fact that he was in his early 40s. You can see a small perfusion defect at the apex, at the infero apex here, that fills in on the rest scan. And this person had extremely low coronary flow reserve of 1.22, meaning that he only increased his blood flow at stress by 20% over rest. And what you see on his coronary angiogram is that he has a diffusely tapering LAD, which turns into a tiny vessel at the apex, but he has no focal stenosis. He definitely also has microvascular dysfunction. So if we use these data, whatever threshold of coronary flow reserve we use, we can have very good specificity, or we can have very good sensitivity, but we can't have both unless we place the patient in context and act like doctors. So let's take a step further, though. We're using the coronary angiogram as the gold standard in all of these studies. And there's been much hay made of the fact that a lot of the coronary angiograms we do are negative. So this is a study of 400,000 patients that was in the New England Journal about almost a decade ago now. And what they showed was that a substantial percentage of the patients actually did not have obstructive CAD. So out of the 400,000, approximately 250,000 had no obstructive coronary artery disease. And this was particularly problematic among women, where they saw a greater preponderance of women having this phenotype of, quote, unnecessary coronary angiography. Importantly, the presence of symptoms and non-invasive testing, so whether they had atypical or no symptoms or typical angina, equivocal, negative, or positive coronary angiography, only had a modest effect. The non-invasive testing only had a modest effect on the likelihood of finding obstructive CAD and angiography. So what are we doing? Are we doing a lot of unnecessary testing? Probably. But on the other hand, we are probably also missing a lot because we have ceded authority over coronary disease to the interventional cardiologists, who have focused predominantly on percentage stenosis. So this is a study that was done in Korea, where they looked at 139 patients, and they did incredibly exquisite testing on them for a variety of things other than epicardial coronary stenosis. So all of them had normal coronary angiograms, but they had angina. And when they investigated further, 45% had endothelial dysfunction, 1 in 5 had microvascular dysfunction, over half had myocardial bridging, and really only about 1 in 4 had no explanation found with careful interrogation. So 75% of those unnecessary coronary angiograms actually probably have an etiology that is related to the coronary circulation. And this has been shown before. So this was the seminal WISE study, which looked at women with ischemic syndromes, but who did not have obstructive coronary artery disease. And in almost 2/3 of these women who came in with positive troponins or other biomarker evidence of myocardial infarction had normal or non-obstructive angiograms. But 79% of them have atheroma when looked at with intravascular ultrasound. And when you ask about vasomotor dysfunction, vasomotor dysfunction was common and was associated with adverse prognosis. So they go on to have more myocardial infarction, more hospitalization, and more death if their coronary arteries have non-obstructive plaque and vasomotor dysfunction, despite having normal epicardial coronary circulation and a non-obstructive angio. We've done some similar work non-invasively with PET, and what you see here is that the distribution of coronary flow reserve in men and women is essentially equivalent in the absence of epicardial coronary disease, as is the prognostic implication. Very similar findings have been seen also by groups in Asia, which have done very careful measurements of both coronary flow reserve and fractional flow reserve, which show that epicardial stenosis is probably more common in men than women, not a surprise, although overall vasomotor dysfunction is equivalently common in both genders. So microvascular disease is not just a women's problem, it is a problem of everyone who has risk factors for coronary disease. So let's talk a little bit about CT-FFR. I made a hint about it earlier. The approach here is to use coronary CT angiography to do very complex fluid dynamics. I promise I won't show the equations. I would say 95% of the speakers who show it don't know what they mean. And to calculate what the FFR would be. This method makes several important boundary conditions assumptions. It assumes we know what the velocity was. And if you recall, I showed you that you need to know the velocity to figure out the pressure. It assumes that you know what the microvascular function is. It assumes you know the patient's responsiveness to adenosine. It assumes you know the LV end diastolic pressure and the right atrial pressure or the coronary sinus pressure. But if you do all of that, what you find is that the relationship between calculated flow reserve on the x-axis and the measured fractional flow reserve on the y-axis is actually pretty good, with a correlation coefficient of 0.73. Bland-Altman doesn't look terrible. But if you go a step further and you say, well, if we want to be 95% accurate with CT-FFR, what range of CT-FFR measurements can I be in and be 95% accurate that I will have a invasive FFR that I know is either on obstructive or not obstructive by traditional criteria? Well, it turns out that you have to be below 0.53. There are a couple of interventionalists in the audience. When was the last time you saw an FFR of less than 0.53? Do I see any hands? Okay, or above 0.93, which is essentially normal. So in anywhere near the gray zone, you can't actually make this measurement and be accurate. It's worse. So if you take those patients who are between 0.7 and 0.8, so that's just below the threshold of abnormal, it turns out that about half of them on invasive measurements are on either side of the threshold for abnormal. So it's a crapshoot anywhere near the threshold where you might actually care. So conclusions of this section. So what is ischemia? So I would say FFR is not a gold standard. It's a proxy for perfusion. I would say that our measurements of flow reserve are practical and accurate measurements of something very closely related to ischemia. They're independently related to prognosis beyond regional stenosis and ischemia by traditional metrics of visual perfusion on a SPECT study. They may have added value for diagnosis in some patients, but we have to be careful how we use that data. But importantly, stenoses only become significant when the microcirculation's capacity to compensate is exhausted. CT-FFR assumes microcirculatory health and therefore will always lack accuracy. So now the more provocative part of my two questions. Does ischemia matter? So I think the most important study done in cardiology in the last 2 decades is this one. This is the COURAGE trial, which took about 2,200 patients with invasive angiography showing coronary artery disease and randomized them to optimal medical therapy or revascularization, essentially all percutaneously, plus standard optimal medical therapy. And what they showed with up to 7 years of follow-up was that there was no difference in outcomes, and if anything, there might have been quantitative but not statistically significant excess of events, largely early with the PCI arm. So what does that mean? That revascularization of stable ischemic heart disease does not help? Well, when we think a little bit further, our standard model of what happens with coronary stenosis is we have a thin cap fibroatheroma with lipid and fibrous components and all sorts of inflammatory cells. At some point, that thin cap ruptures, a thrombus forms, and that can either heal and lead to a healed plaque with a greater degree of stenosis, or it can cause downstream myocardial infarction, or both. So are more stenotic plaques more likely to rupture? So this was a prospective study, one of the few that was done with intravascular imaging, where they took these patients and then they followed them afterwards and saw whether the plaques that were imaged were likely to rupture or not. And all thin cap fibroatheromas were far more likely to rupture and present with downstream myocardial infarction than atheromas that did not have a thin cap. But if you look at those that have a smaller luminal area and had a percentage stenosis greater than 70% or the combination, they were even more likely to rupture. So we're always taught, well, it's those non-obstructive stenoses that are more likely to rupture and create downstream myocardial infarctions. So this is prospective data showing that the more obstructive a lesion, the more likely it is to cause an infarct downstream. How do I rationalize that with decades of observational data in the reverse? Well, you look at the same study and you ask, where were the majority of plaque ruptures that they found? So on an individual plaque basis, those more severe stenoses are more likely to rupture. But the majority of rupture events, in fact, the vast majority of them came from non-obstructive vessels. Right? And the reason for that is there are way more quantitatively in number non-obstructive stenoses in any given individual. And that corresponds much more closely to the total plaque burden than the individual most severe stenosis that we end up seeing in our coronary angiography report. So does ischemia then really matter if ischemia is finding those obstructive, if ischemia finds those obstructive stenoses, and it's not the obstructive stenoses that are most likely to cause an infarct, even if they are slightly more likely to infarct in the first place? Excuse me. So these are very old data, and there have been dozens of similar experiments done. This was done in a dog where you decrease coronary blood flow, and what you find is that causes abnormalities in potassium handling and causes increases in ectopic beats and eventually VT and VF. And this has been shown time and time and time again with many, many, many dog experiments, and it's to the point where that's not really the interesting point anymore, but what you can do to mitigate the effects of ischemia. And lots of experimental electrophysiologists and coronary physiologists have shown that if we give beta blockers in these kinds of models, it decreases the rate of these ectopic beats and decreases the propensity for fatal or potentially fatal arrhythmias, and there have been lots of other kinds of molecular and non-molecular studies since that time as well. So this is almost a truism. So how do we rationalize these together? Well, maybe that's only a feature of acute ischemia. These are data on the left from the Duke cardiac database, where they looked at the rate of sudden cardiac death downstream of SPECT myocardial perfusion imaging. And these curves divide the population based on EF. And the top two have preserved EF over 35%, and the bottom two are below 35%. But in each of these categories, the likelihood of developing sudden cardiac death was related to the amount of ischemia present on the scan. We've done very similar work here now, diving not just into sudden cardiac death, but looking at those patients who have implantable cardiac devices and looking at the rate of VT and VF and using more precise quantitative measures of myocardial blood flow. And Mike Ghanem, one of our STAR EP fellows, showed recently that, in fact, myocardial perfusion is predictive of both ventricular tachycardia and ventricular fibrillation. So it might have an implication in chronic ischemia. I'm seeing things on both sides. How do I rationalize? Well, the best data observationally, I believe, came from the Cedars-Sinai heart group. And what they looked at was 14,000 scans for perfusion imaging, largely SPECT perfusion imaging. And in a very complex statistical modeling exercise, they showed that depending on the percentage myocardial ischemia, your hazard ratio for cardiac death depended on whether you had medical therapy or early revascularization. And those patients with greater than about 12.5% ischemia did better with early revascularization, and those patients with less probably did better with medical therapy alone. But of course, it's not projecting very well, but there are some dotted lines that show relatively wide confidence intervals, and we're probably not confident that these are different until we're hitting myocardial ischemia levels somewhere around 20 or 25%. If you look at a sub-study of the COURAGE trial, remember, showed that overall there was no difference with early revascularization or medical therapy alone. But if you take those patients who had improvement in their level of ischemia from a pre-randomization stress test compared to a post-randomization stress test at about 6 months, you find that the rate of events differed by almost a factor of 2, that if a patient had reduction of ischemia by just 5%, just a pretty small amount, they did substantially better. Looking at a meta-analysis done by David Brown and colleagues at WashU, if you take all of the data together on revascularization of stable ischemic heart disease based on ischemia, either using FFR measurements of ischemia invasively or perfusion imaging, what you find is that there's no effect on death, non-fatal myocardial infarction, unplanned revascularization, or even angina. So we have a contradiction. We say that ischemia in the acute setting in animal models leads to VT and VF and all these bad things. We have observational data that shows that with more ischemia, you are likely to do worse and have more sudden cardiac death and perhaps do better with revascularization. But all the sub-studies, albeit mostly not randomized sub-studies, but embedded within randomized trials, show that there is no improvement in outcomes with revascularization of ischemia. So how do we resolve this contradiction? Well, one possibility is that ischemia is a proxy for plaque burden. For every one of those severe stenoses with the slightly higher rate of plaque rupture, you have many, many of those non-obstructive plaques that are more on net add up to a greater risk of plaque rupture and downstream myocardial infarction. That's one possibility. Another possibility is that mild to moderate ischemia, which is the majority of the ischemia we see, may not have much clinical relevance in the setting of our patients having low physical exertion in their daily lives and having widespread beta blockade. Maybe what we really need to worry about is a degree of ischemia that isn't in the mild to moderate spectrum, but is at a much higher end of the range. So to address this question, the NHLBI has funded the ischemia trial. So the ischemia trial takes patients with by design, moderate to severe ischemia determined by an imaging stress test. It takes them and does a blinded CT coronary angiogram and asks, do they have significant coronary artery disease, meaning it's not a false positive stress test. And as long as those things are true, they get randomized to invasive strategy, meaning they get a cath, they get optimal medical therapy, and if they have a stenosis, they get revascularized by the best approach, whether that's percutaneous or bypass surgery. And if they get randomized to the conservative arm, they get optimal medical therapy alone, and they only get a cath if they have refractory symptoms or go on to have an infarction or things of that sort. And the goal was to look at a primary endpoint of cardiac death, or MI, but the study has evolved in a couple of important ways. First is that recruitment was really hard. So even despite all the uncertainty and conflicting evidence in this area, it was difficult to get American cardiologists to recruit patients. So first, they changed the inclusion criteria to allow stress EKG-based metrics only to let patients who have only EKG changes on a treadmill with no imaging evidence of perfusion defects or LV dysfunction to get into the trial. Well, these are all healthier people because they can run on a treadmill. And as you all probably have experienced, there's a significant rate of ST segment abnormalities on treadmill ECGs that are not correlated with perfusion defects or prognostic relevance even. So the rate of events has been low, and after interim analyses, the composite endpoint has been changed from cardiac death and MI to also incorporate resuscitated cardiac death, arrest, which seems reasonable given the mechanism, but softer endpoints as well of hospitalization for unstable angina or heart failure. So this has been a very controversial trial with a decrease in the planned sample size from 8,000 to 5,000. Recruitment is now complete. The effective mean follow-up has also decreased because of later average recruitment. The endpoint, as I mentioned, has changed after a blinded interim analysis occurred. And there's been important changes to the inclusion criteria that include people with relatively mild amounts of myocardial ischemia. So if the question is it total plaque burden or severe stenoses that matter, I would say it's likely additive. This is what I believe in my heart of hearts, although I have no strong evidence for this. Plaque burden indicates the potential for acute plaque rupture, but I also believe that ischemia from severe stenosis may predict arrhythmia and heart failure. And I showed some data on that, and there is mountains of additional data, all observational, mostly from single centers. There's no specific treatment that depends on the extent of plaque burden beyond optimal medical therapy. And revascularization of ischemia may reduce sudden cardiac death and heart failure, but we don't really know that. My suspicion is that post hoc analyses of ischemia may finally start to disentangle these issues, assuming we have sufficient patients and sufficient power with enough people who have true moderate to severe ischemia. So, in conclusion, ischemia is associated with increased risk in stable ischemic heart disease, but the benefit of revascularization of ischemia in stable ischemic heart disease is still unknown. The ischemia trial may answer these questions, but the inclusion criteria now include patients without substantial amounts of ischemia. So you can be in ischemia with minimal ischemia. So I want to acknowledge many important colleagues and collaborators. A lot of the work that we do is done by our STAR fellows. I showed you some work by Mike Ghanem. There are several others who have done really great work that I didn't highlight today because they're in slightly different directions. I have had the privilege of working with many really spectacular collaborators here, both within our nuclear cardiology group, but also more broadly in cardiology in general and across the medical school and university. And I've also been privileged and lucky to have support from several branches of the NIH, as well as some foundations to support our work, much of which I haven't had the opportunity to show you today, but maybe on some other day. And with that, thank you.
Terrific. Very important question. Anybody have a question for Dr. Barkley? Yes.
There's been some studies recently showing that diabetics much better catheters versus stenting. Is that because the vessel that gets removed is removing part of the plaque burden that they're confronted with?
So the question was that there's been both new and old evidence that diabetics do better with bypass surgery compared to percutaneous revascularization. This is an extremely hot topic and controversial, but I think that overall the teaching is that if you have a diabetic with proximal LAD disease or left main disease or something close to that, will do better with bypass surgery, and these data go back several decades. The theory is that when you bypass this patient, you provide an internal mammary graft that allows for the potential of plaque rupture in a large segment of the proximal to mid-LAD without having the risk of dying from such an event, right? So that's the theory behind it. There are maybe other factors as well in this. So for one, historically, diabetics did not do well with many of the early generation stents with higher risks of restenosis and other complications. So that has evolved, and there are some groups that believe that percutaneous approaches in most patients are equivalent. I don't think that's our opinion predominantly here, but this is what I would say is stay tuned. There's the evolving data.
Other questions, Dr. Rubenfire?
Greg, that was really superb. You and I have talked about this before, but I'm sure not able to give the answer myself. The value of exercise testing includes the 1-minute heart rate recovery, includes chronotropic confidence, blood pressure response, the MET level people get to. Does that change your thinking about which test is best from a prognostic point of view?
That's a great question. So the question was that when we do exercise testing, we get a variety of other parameters like heart rate recovery, the total exercise capacity, response to in terms of blood pressure and heart rate. There may have been some other things that Dr. Rubenfire, there's a page-long list of parameters that have been related to prognosis. And you don't get that with vasodilator stress testing. And I think there are trade-offs here, but I would say a few important points. One is that the majority of our patients today probably cannot exercise more than 5 to 6 METs. It's a shame, but that's the observation that's been shown in registry after registry. And in those patients who can do more than 8 or 10 METs, the likelihood that they have obstructive coronary disease is extremely low. And that's been shown in several cohorts as well. So what I would argue is that if we can identify those people who have a relatively preserved exercise capacity based on simple questionnaires, and there's evidence that we can do that we could probably do a much better job of saying these are people who are marathon runners, and unless they have an exceptionally good story for coronary artery disease, probably need no further testing. These are a group of people where the exertional capacity is for certain low, and knowing whether they can do 3 METs or 4 METs probably has little added value. And conversely, knowing that they had a good stress test might be of greater value. And then there's that intermediate group where I don't really know, based on their questionnaires and their history, whether they can do 4 METs or 8 METs. And that may be a group where you're absolutely right. But I think we need to, in order to do this better, I think we need to have a more integrated approach to how we do stress testing. Right now, we're relying on the referring doctor to make that judgment for the most part and to select the test that they feel is most appropriate. And I think in many cases, they're doing a great job. But in other cases, they may not be aware of all of the data. They may have pressures of time and resources for doing that stratification. And the vision that I think I would have is that downstream, we integrate this as more of a what is the best coronary evaluation for my patient. And in some cases, that may be no further testing. In other cases, it may be anatomic imaging with CTA, and some it might be exercise testing. But I think we need to add science to and develop a better algorithm for figuring out who does best rather than the gut.
Other questions? Dr. Malamoto.
So, very interesting. How do you feel ischemia with symptoms?
Could you expand on that?
Well, we see this a lot, right? So symptoms are a driver for revascularization. Oftentimes, in most people with stable ischemic heart disease, the reason we often push for it. Do you always see symptoms with ischemia? Do you always see ischemia with symptoms?
So Dr. Nellamothu asks a very provocative question about the relationship between symptoms and ischemia on non-invasive testing and resolution of symptoms, presumably with revascularization. And there's all sorts of philosophical issues that arise here. So you have two patients that come to you with exactly the same story. You send them both to the cath lab, and one has an 85% mid-LAD and the other has clean coronaries. You tell one patient, well, we stented you, you're better, now take your statin, your aspirin, your Plavix, and the other one we say, don't worry about it, it was in your head. You'll be fine. I don't think we're doing either of those patients a service. And I think we need to think a lot more about what it is that we're going after. But I don't have the answers.
Okay, I'd like to take the last question. Is a perfusion reserve, or however we term it now, a fixed property of a myocardial mass, or does it vary with time of day, circadian biology? Does it vary with estrus cycle? Or how do we think of that?
So this is really interesting. So the stress myocardial blood flow, so that is the blood flow that you get under adenosine or regadenoson or dipyridamole, should be, in theory, the maximum blood flow possible. On the other hand, the resting blood flow changes. We know it changes. Your heart rate goes up, your resting blood flow goes up to compensate. That's the whole point of that plateau rising. You have changes in your microcirculatory tone because of hormonal conditions, and resting blood flow will change. And so the ratio changes correspondingly to that. But I believe that the things that change stress blood flow are long-term processes. So if you change vascular health by improving glycemic control, by improving blood pressure, not in the short run, but over a duration of time, cholesterol, exercise training potentially, those may affect your stress blood flow, which is really likely to be reflective of improved coronary health in a meaningful way. Whereas the things that are changing resting blood flow, they may change your symptom state, your vulnerability to arrhythmias, your ability to respond. If you are well compensated with a lower blood flow because your metabolic efficiency has improved, that's probably a good thing. But there are many ways to change that may not actually reflect a change in the health of the coronary vasculature itself, right?
I'd like to thank Dr. Murthy for a really scholarly lecture.
I hope the first half wasn't too...
I don't know. Yeah. I learned a lot. It's even hard to think of a lot to learn.
Yeah.
It's great.